Okay, guys, thanks for coming. I just wanted to talk a little bit about metabolic acidosis because I feel like it's one of those topics, those places where we see these patients a lot, and maybe we don't think a ton about how it impacts our care. And so to start out, I'm going to give you a little bit of a case study. So you guys are going out, let's say it's an inter-facility, a small facility that you're going out to, a little hospital here locally. And you get there. On the way, they say the patient's unresponsive, 45-year-old male, and doesn't seem to be maintaining their airway, and they're going to try and get them intubated before you get there, and you're on short final as you're getting this information. So you get in there, you go in, and it's chaotic, right? There's kind of people everywhere. Thank goodness you're here sort of thing has happened, and you get in and you see this 45-year-old male. Like I said, he's unresponsive. GCS is 3. He's pale, and the doc grabs you and says, "Will you come intubate this patient?" So, you do that, right? And you put in an 8-0, 24 of the teeth, everything's great. And they're like, "Okay, go." And they're handing you labs and they're handing you information as you're going out the door. So you don't get a real great report. It's kind of, one of those things where the patient hadn't been there for very long and he was kind of crashing and they just wanted to get him out the door. The information that you do get, as you're leaving, is that the heart rate after you've intubated is 116. There's SATs pre-intubation. We're in the 70s and 80s. So you had a little bit of vomit too, so that had been suctioned out, but you clean that out whenever you tubed them. And the blood pressure was 90/60. Someone checked the sugar while you were doing that, and they told you it was 475. They had drawn labs, and they were handing you those labs, so you don't really get a chance to look at those before you get out to the aircraft. So you're in the aircraft now. You're getting ready to set them up on the vent. Your partner mentions that patients kind of seems like they're breathing against the bag quite a lot. You'd use, well, I don't know what you'd use. We'll ask you what you'd use, but he's not paralyzed anymore, or he's at least sedated but not paralyzed. And respiratory rate, like when your partner's bagging, is in the 40s. So what kind of vent settings do you guys want to do? So I sort of kick it off. I don't have a lot of information, but what are you thinking when you start hearing some of those numbers and some of those kind of responses on this patient? I'm trying to think. Probably in this area.
I would probably think that you would want to start by matching fairly close to their respiratory rate. You would want a higher than normal respiratory rate to start with. Yeah,
and so why would you want to do that versus like our guidelines say 16 or 18 or 20 or even lower. So you're saying I'm gonna start that respiratory rate at like 40.
Yeah. So his body's used to where he has become for
He's
too long.
compensating.
And for us to match that and help him get back to normal, we can't just drop him and allow his body to catapult into a hole.
Okay, yeah, and I 100% totally agree. So what other maybe changes then? Whenever if I'm going to hit the rate up higher, what do I need to also change so that we don't have any other negative?
Your volume, you can decrease it.
So what are we looking at overall? Where are we trying to target? If I'm increasing my rate, I'm decreasing my volume, and I'm kind of keeping I want to keep that patient in a ballpark for minute volume?
Correct.
Yeah, so I'm going to be looking at minute volume. I want to be kind of in the 4 to 8 liters. So, as I go up higher on those rates, I'm going to be really dropping them down. I'm going to be keeping an eye probably on like the exhale tidal volume, for instance. What other settings? So, even backing up even further, is it important maybe to think about, using assist control versus SIMV?
Sure. I would normally pick assist control.
Most of us would, right? Because we're going to want to do the P-flat.
Sure.
We don't really feel pushed to do that, but
sure. I guess it would be better to go with SIMV if he's breathing on his own some, right?
Right, and so then that's what we're going to kind of dive in. And I don't know that there's necessarily a right answer on it. All this sort of clinical picture, it's going to be different for each patient, but definitely what both of you said, where the patient's compensating, right? So he's in some sort of acidosis. We don't know at this point whether it's respiratory, metabolic. Look at pH, look at our labs, but acutely, if they're in some sort of acidosis, what's our first line of defense? How are we going to compensate for that? What system?
Respiratory.
We use our respiratory system, right? And so, we're trying to balance, the body's trying to balance this out. And so, when we talk about metabolic acidosis or any kind of acidosis, what is the definition, really, of metabolic acidosis? So, what's happening? When we look at the kind of the formula, we're looking at this side, right? What's affected on this side, and we're balancing out with the stuff over here, right? So our systemic pH is dropped, And it's either because, you know, our bicarb is gone, or, you know, we've retained too much, or have too many hydrogen ions. So, you know, as a buffer system, we're using respiratory, and it's going to be acute, and it's going to be really quick. And so for us to cut that out, we would worsen, right? Sure. We would worsen it. We remove their line of defense. Now, on the other side, the chronic or the long term, that second line of defense, what buffer system are we going to be using? We're going to use our kidneys, right? Because that's where, you know, we're gonna adjust. We're going to be able to kind of, you know, retain or pull back that, recycle back that bicarb and try and balance out that way. But it's going to take days, and that's assuming that the kidneys are working. Right? Because, you know, we can be in acidosis because there's a kidney function. In fact, we could have, you know, that's one of the most common causes, right? Of renal tubular acidosis is for that on that non-high anion gap side. So, you know, just sort of just a little basic review. So let's say we're in there, you know, we pulled out the VBG or the ABG, depending on where we were at ISTAT or from the hospital, and we've got this pH now that we looked at, and you're like, aha, I have an epiphyseal moment, and we see a pH on this gentleman. This is pre-innovation of 7.0. I'll write it in here. 7.0. And we're showing on our CO2 now, and it actually closely correlates with the one that they had, a CO2 in the 20s.
Makes sense, breathing at 40.
Right, right. You know, and when we see that, if we just took that one piece of information, we took that patient, or if someone's been bagging them, and we're like, oh, their CO2's at 20, that piece of information alone is going to tell us to do what? You know, our gut instinct would be like, man, slow that down.
Yeah. Right.
You know? But on this patient, we're not going to get that number up. You know, we're not. We shouldn't. You know, we want them to compensate. And let's say this guy had a bicarb of like 18. So, you know, if we remember some of these other simple things that we learned in school, what is Rome? It's not just, you know, an empire that failed, right? Yeah. So, you guys remember?
Yeah. Respiratory opposite, metabolic equal.
Yeah, respiratory. So we have mnemonics, and I'm bad to remember the mnemonic and not really remember what it means.
Yeah.
But respiratory opposite, metabolic equal. So we've got a pH that is high or low?
Low.
So we want it to be 7.35 to 4.5, right? So that's normal. So we want it to be low. The CO2, is the CO2 low?
Yes.
Yeah, CO2 is low. Is bicarb low?
Yeah.
Yeah.
Or high, yeah. So bicarb's low as well. So we want this to be 35 to 45, right?
Mm-hmm.
And I want this to be 22 to what? 26. Well, what does it say when they're all low? What do you think's going on? Respiratory opposite, metabolic equal. So when metabolic is equal, so we're going to look at, these are our metabolic, this is our metabolic one we're going to look at first. So I know that it's a metabolic, if it's low, the pH is low, it's acidosis, right? So metabolic acidosis. Well, what's up with this CO2? Why is that all low too?
Probably because they're trying to compensate.
Right, so this would be a metabolic acidosis that's partially compensated. And we say partially compensated because the pH hasn't gotten back close into a normal range. And so if it were fully compensated, then it would have, right? And the bicarb would still be low. So, dude is sick, right? No one disagrees with that. Now, you know, we've got the vent set up how we want it. We're keeping an eye on this. We're not trying to get the CO2 back up high. You know, we're just kind of keeping an eye on SAT. We're just keeping an eye on pressure. You know, you think about your trauma patients when they get a metabolic acidosis. What happens to them? They die.
Yeah.
Yeah, right? They do really badly. This guy isn't a trauma patient, right? So what's the number that jumped out at you? The other number that was kind of a little bit wonky as you were walking out the door, I gave you in the case study.
Glucose was over 400.
The glucose is over 400. So what's the, I mean, just
Diabetic
kind of give me the DKA, right?
Yeah.
You know, and so, okay, if I think DKA, then I'm going to think high anion gap, metabolic acidosis, and I can do my anion gap, and we'll do it here in a second if we got time. But just to remember, you all remember that other mnemonic that we memorized some long ago for some test for remembering high anion gap, because there's a lot of different ones. And with a high anion gap, it's easy to kind of, for me at least, to get them a little bit confused. non-high, the normal anion gap, it's really just diabetes and that RTA, right? That renal tubular acidosis, to kind of be the 90%. I mean, there's a mnemonic for heart ups, there's all these different mnemonics. Not as important to probably remember those, but for the high anion gap, for that anion gap that's going to be greater than 16, is mud piles. Did anybody remember that?
Vaguely.
Okay. So mud piles is going to, I'll just give it to you fast because I think we're running a little bit low on time, but methanol, right? You better remember what the kind of reversal or kind of the treatment's going to be for methazole. Uremia, DKA, and don't forget like starvation ketoacidosis and alcoholic ketoacidosis. Let's see, propylene glycol. So this is, you know, when the kids drink the antifreeze. Oh, there's 3 here. Oh, so we got iron. So niazide. And you can tag in infection if you want. So you can kind of tag that into the next one as well. How about L? I feel like I'm giving you the answers. Yes. Lactic acidosis. So, you know, this is kind of almost the catch-all, right? So this is where, you know, your shock states kind of fall in there, your cyanide, your CO, your trauma patients, really, who end up with metabolic acidosis. Do you have a question? No. Okay. Ethylene glycol. I don't have terrible handwriting. And salicylates. And what are we saying with salicylates? It's fun to say, salicylates.
Yes.
Yeah, it's just aspirin. So, you know, is it possible to have this in multiple states? So you can have the metabolic acidosis of a high anion gap. So this patient, when I say high anion gap, what am I saying? Well, my electrolytes are screwed up. That's what I'm saying. I've got these balances that are all out of whack, and it's not just bicarb and the hydrogen ion, it's also, you know, my sodium and my chloride are also destroyed. Maybe it's because of, you know, maybe it's because of one of these things. It's a DKA or one of these others. But can you have concomitant issues? Sure you can. You can have the DKA patient who's vomiting, right? And so when we're losing all of that stuff that's in our gastric acid, and it's gonna get all messed up. And you're not gonna maybe be able to see as clearly what it is with just these 3 simple numbers. You're gonna have to add some things in. And so that's where we add in that, we're talking about anion gap. And so if this guy's, what would be a normal sodium, by the way?
135 to 145.
Yeah, so this is going to be, you know, that's on the printout, right? So 135, 145. I learned 96 to 106. I guess that's what everybody, 3.5 to 5, 4.5, whatever. We said 22, 26, and, you know, vitamin, creatinine, and glucose. But, so let's say his, you know, his sodium is, I think I actually figured one out here. Yeah, like 148 is high. Chloride's going to be probably low, so, 100. What did I say? What did I say? Sorry.
149.
Yeah, let's say 148. Make it easy. And then 18. So if you do that, you add those 118, subtract it from 148. What do we get?
48.
We get. We get 30.
Oh yeah.
So when we said at the beginning, plus or minus 4 from 12, so anything over 16 is going to be high on, 30, clearly. So we're in one of these. We already knew that. You know, we kind of knew, or suspected it anyway. But here's a little thing that I thought was kind of cool. I know that it's not as simple as just one number. I know that it's not as simple often as just one diagnosis. So if I look at the delta gap, if I look at the sodium, so 148. I subtract straight out the chloride, so it gives me 48, and I subtract just a number to remember, 36. From it, if I'm over 12, then I'm in I'm a high anion gap as well as a concomitant metabolic alkalosis. Now you're like, okay, now my brain is spinning, okay? Because the pH doesn't make any sense. But one outweighs the other, right? And so your metabolic alkalosis patient, that's like your vomiting. That's where you're going to get that. Maybe you have the patient that it's in it's below -6. So you get down, you know, you got it, you subtract that -36, or subtract 36 out, and you get, you know, -10, then you've got a normal anion gap acidosis and a high anion gap acidosis patient. So that's when you get to your hard ups, to those that diarrhea patient, right? Or if you're just in this range, -6 to 6, it's just simple high anion gap. Now, we don't just take this delta gap and apply it to all of our patients, right? We apply it only to these patients that we suspect metabolic acidosis. We can get some absolutely ridiculous kind of diagnoses if we just use this alone. But if we use it in coordination with our anion gap calculation or the number that we've gotten from our machine, then it can kind of lead us, help us figure out why maybe something isn't adding up. So, any questions? Guys, thank you so much. I appreciate it.